afternoon, everyone, and welcome to today's Public Health Ontario Microbiology Rounds. This is the third presentation for this year's series, and we have a topic that is near and dear to my heart, which is microbiology in low-resource settings, current practice, challenges, and future directions. My name is Melissa Richard Greenblatt, and I'm a clinical microbiologist at Public Health Ontario, and I will have the pleasure of moderating today's session. I now have a few housekeeping items. So the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session, and a discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@ohpp.ca, and we'll try to address these challenges. I would like to also state that as a moderator of this session, I have no conflicts of interest. So before we get started, I would like to introduce our three speakers for today's presentation. So the first is Dr. Saqib Birza. He is a physician with an interest in planetary health and neglected tropical diseases. He completed his PhD in leishmaniasis at the Institute of Tropical Medicine in Antwerp and is an honorary associate professor at the London School of Hygiene and Tropical Medicine. After over a decade working in the field with Doctors Without Borders, he is now medical director of Health in Harmony, a planetary health organization that aims to improve human and forest health through a One Health approach. Our second speaker today is Dr. Marta Gonzalez-San. She's an infectious diseases, medical microbiology, and in general internal medicine consultant at the University Hospital of Ramon y Cajal in Madrid, Spain. She also holds a post as tropical medicine referent at Doctors Without Borders. She has a special interest in neglected tropical diseases, has collaborated with multiple NGOs, and teaches regularly at different institutions, such as the London School of Hygiene and Tropical Medicine and Charity in Berlin. And last but certainly not least, we have Dr. Arjun Chandana, who is an infectious diseases registrar and Wellcome Trust doctoral training fellow, interested in supporting the development of clinical infection services in under-resourced settings. He has spent much of his time in the last decade working in Southeast Asia and collaborates on a number of research projects in partnership with Doctors Without Borders. He's currently completing his PhD with Oxford University at the Angkor Hospital for Children in Cambodia. So thank you everyone for joining us today, and I will pass it off to Saqib to get started.
Thank you, Melissa, for that very kind introduction, and thank you to Public Health Ontario for the opportunity to give this lecture, which I hope will be of interest to the group who are attending. So, first of all, just a quick summary of who we are. Essentially, we're all doctors who've had a fair amount of experience working in low-resource settings in different contexts, ranging from South America, Africa, across the Middle East, and Asia. Two of us are microbiologists, ID physicians, and one that's myself as a journalist who's been more involved over the last few years with building the hospitals for MSF in the different contexts that we've been working in. We're actually all experienced with MSF and either working with currently or alongside them, and all of us have got a long-standing interest in working towards improving microbiology access in the different settings that we work in. So, who are MSF? I'm going to talk a little bit about the organization, because we've mentioned it a couple of times already, just in case some of you may not be aware of it. Essentially, it's a private organization, international NGO. It's probably the biggest humanitarian medical NGO in the world, and it's a loose association of medical professionals and paramedics and others who are genuinely interested in the mission of the organization, which is providing assistance to populations in distress, traditionally mostly in conflict areas, kind of the first in, last out approach, and the thing that makes MSF slightly different to others is that most of the funding that's paid to MSF comes from people's pockets rather than institutional donations from governments and so on. And as such, there's no requirement, there's no duty for MSF to follow anyone's mandate. So it's really done, all decisions of where to intervene, how to intervene, and when to intervene are made by MSF themselves based on needs of the population. So just to talk a little bit about the current scenario. Where do we work? So we work in about over 70 countries across the world. Typically, as I said, the MSF is known for working in conflict zones, but actually the scope of work of MSF is much wider than that. We do everything from chronic long-standing conflicts to very secure areas where there are neglected populations, and ranging to acute outbreaks such as Ebola. We also focus on very neglected populations, so specific areas like India where perhaps you might not expect MSF to be working. We focus on neglected tropical diseases such as leishmaniasis, and treatment failures in tuberculosis and HIV/AIDS for these populations who tend to be quite neglected, and for whom research and development is not really a priority for the pharmaceutical companies to provide treatments. We provide care ranging from mobile clinics, the smallest mobile clinic in the very middle of South Sudan or Central African Republic, all the way up to large-scale specialized pediatric hospitals in Bangladesh. So we really have a very wide scope of work, and I think from that perspective, we're looking at some of the microbiology needs and requirements and challenges that we face today. Because we don't really see much microbiology-wise when it comes to access in the countries that we work, in the places that we work. Generally speaking, as a rule of thumb, microbiology services per se, when it comes to antibiograms and so on, are not available in any of the hospitals that we work within, with the exception of areas or countries where we have access to them within the existing health infrastructure or ecosystem around us. And this is a major gap in the work that we do. It's a wicked problem. It's very difficult to solve considering some of the challenges that we'll talk a little bit about, but we are working on solutions which will be presented during the presentation today. So just a little bit about the current scenario from the global health perspective. We all know that AMRs is a big threat to global health systems across the board. And if you look at the number of deaths that are associated with AMR, this is from a recent publication in the Lancet, it's as high as 27.3 out of 100,000 in Western Sub-Saharan Africa. To put that in comparison, that's 6 in 100,000 in Australia. There are, however, huge gaps in knowledge when it comes to where we are with antibiotics and with general microbiology services in limited resource settings. A good paper that was recently published showed that even in the DRC, which is really one of the weakest health systems across the world globally, in a neonatal unit, nearly 75% of all isolates are resistant to the WHO recommended antibiotics, which are the antibiotics that we have on tap in these sorts of settings. Getting higher level antibiotics are very difficult and very expensive, so they tend not to be available to the population. So how does this impact low resource settings? We just don't really know how to diagnose and how to identify bugs there. We don't really have the technology or the workforce, the skilled workforce to be able to do this. And as such, we use empirical treatment as a standard of care. We will wait for children to come back to us or adults to come back to us with a failed treatment or not responding. Then we'll switch them to the next line and so on and so on. We don't have any access to diagnostics and to sensitivities. And this is primarily because we don't really have the infrastructure and the expertise on the ground to support that. Microbiologists are actually a rare species across the world, although obviously not in resource-rich countries. But in the sorts of places that we work, they are very difficult to find. And even when you do find them, getting the equipment to support the work that they do is extremely challenging. And of course, microbiology in itself, services are quite complex to introduce, and this is something that Marta's going to talk about from the governance side and what the challenges are and how can we face those. So we are even trying to roll these services out. It's very challenging. even getting machines across to function in the temperatures where we don't have constant air conditioning and so on is very difficult. Keeping reagents stable, the number of cold chain ruptures that we receive, even with our drugs, let alone our reagents, is very frequent and very difficult to manage. Maintenance, getting AMC contracts is obviously not going to be something that we can do. So we have to train our own biomedical staff to be able to fix these machines, which of course is very hard to do if these machines are automated and very complicated. And we don't really have any silver bullets at the moment. Yes, there is some hope with regards to whole genome sequencing. We've seen some results with that in Ebola more recently, but still it's a really long way away from being somewhere that we can use it in a routine setting. Okay, so this comes down to the primary question, which we're hoping to raise some light upon by the end of this presentation. Can high-quality clinical bacteriology be implemented in the most remote, challenging, and underserved areas of the world to improve treatment and surveillance of antimicrobial resistant infections? This is the core question that we're looking to answer. So what we're going to do in this presentation, some of the objectives, we're going to go through the current use of microbiology in such settings as I've described. We're going to identify the challenges and some of the pitfalls of what the mechanisms of introducing, some success stories, some failures, some examples of what to do and what not to do. Talk quite a lot about the laboratory governance issues. Now, this is, sometimes it can be a bit dry, but it really is critical on implementing successful microservices in these sorts of settings. And also thinking about what your roles could be in supporting expansion of microbiology services in such settings. And of course, finally, to have fun and enjoy the presentation. So with that, I'm going to hand over to Martha and take it away.
Thank you, Saqib, and thank you, Public Health Ontario, for putting together such a fantastic event. For all of us, we're going to jump on a plane and we're going to go back on time to Central African Republic, where I did my first mission with MSF. I'm talking about 2010, all right? So 12 years. And I think it's important because I'm going to show you what the reality was when I was working there and what the reality is now. And I was working in Cabo. This is just like 60 kilometers in the border with Chad. And on the left, you can see where we lived, and Doctors Without Borders and a specific Doctors Without Borders Spain. We tend to work in conflict areas, so we have these kind of signs saying, please don't come in with weapons. And then on the right, you have the entrance to the hospital. So let's go in. And on the bottom right, you'll see a typical district hospital in Africa, where you have the OPD, well, that is exactly antenatal care, and you have all the mums waiting to be seen. And at the end of the picture, you can see a door that leads us into the lab. And on the top left, you've got the lab, and you can see several things. You can see a microscope. Hooray. You can see a water filter, that is that metallic cylinder at the back, and you can see a fridge. So we're not doing very badly. And you can see also the one of my colleagues on the microscope, he's writing on a notebook the results for the patients. That fridge was operated with petrol, and the microscope that seems to be plugged is not really plugged, because we only had the generator on during the night and during the day if we needed oxygen for any of our patients. So we had to use most of the time the little mirror that you can see on the bottom left of the slide to use the sun to power our microscope. And just behind my colleague with the white coat, you cannot see it, but there was the instrument that we have on the top right, that is a manual centrifuge. So limited things, but we'll see what we can do with them. So basically, you are all familiar with this kind of quality system essentials in microbiology. I'm not going to run you through all of them, but I'm going to tell you how MSF works with it. So the first one, the management laboratory quality manual, comes directly from headquarters, and we have this kind of book that takes us from safety, that is also included here, to how to set a lab, the initial equipment needed, and all the different SOPs for all the tests that can be done. The next one will be customer focus, that I think Saqib has been very, very clear on that. MSF is there for the people in need, so I won't stay with that. And then we have personal, and Saqib has already mentioned how difficult it can be to find people with adequate training, and some of the ways in which we can tackle that is to do task shifting and sharing, getting nurses to learn how to do a little bit of lab test. We always get people going regularly to the projects to work on the training and refresh what is being done, and also we try our best to retain those people that are being trained, by giving them career opportunities and making sure they stay with us. One that is easy, at least for me, is supply. We have a fantastic supply team, but of course you can understand that going to places like Central African Republic and getting equipment there is not as straightforward. So you get these kind of airstrips that are just a field, and you go in a small plane that looks a bit like Indiana Jones, and then you go by road through really, really dusty, if you're lucky, or muddy if you're unlucky, roads to get you to your hospital. And with all these, we can see what we were meant to be doing. And as I told you, we were working in this district hospital, and we would be at level 2. But there are different levels of what can be done or what you should aim for, depending on your type of facility. We're going to focus on the one of our example today. And in this one, to be honest, we should have a general medical laboratory with food blood count, biochemistry, CSF analysis. So if you look at it, yes, we had a manual food blood count. I don't know if any of you have done that ever, but it's really painful and it's very time consuming. And then we could do gram stains, and we could do basic parasitology, looking for, in this case, schistoeggs. We had RDTs, of course, for malaria, for example, and we could do some other basic tests like agglutinations, RPR for syphilis. In 2010, some of these things weren't that fashionable, if you want. So AMR, although people were talking about AMR, the collective thought was that maybe AMR couldn't be done, surveillance couldn't be done in the field, and that stewardship or infection control was really hard, let alone thinking of doing culture ID or AST of any samples. So that was a limitation when it was there. So I only had very, very basic tools. So let's see what we can do with them, though. We're going to do a case. We've got a 20-year-old female. She's the one at the end of the ward, which I think it's always a concern. People at the end of the wards do worse than people at the beginning. And she's been readmitted during the malaria season. We're in full peak palu, like they call it. And she says she's been having persistent fevers for 3 weeks, some abdominal pain, but no clear diarrhea. And she was treated for malaria as an outpatient a week ago. On examination, she's got a temperature, She looks quite unwell, and she's got abdominal pain, but no guarding or band. So with what we've got available, we do some tests. We do a malaria RDT, which is positive. We do a beetle test, which is negative. We do a pregnancy test, which is negative, and we request a full blood count, but the lab technician is very busy in the middle of the peak palu to take the time to do a full blood count for us. So basically, if we think about it with the tools that we have that are limited, we know we are in a high prevalence area for malaria. And therefore, that has to make us think that severe malaria is quite unlikely in adults. They already had it through childhood, and they don't normally become very unwell. So through this time of the year, you have your PIDS ward absolutely fully packed, but your other ward is kind of normal, business as usual. It's different in the case of pregnant women, and that's why the pregnancy test was relevant in this case. So malaria shouldn't be clinically at the top of my options. The other thing that we have to know, and that is something that we all have to know in our labs, is what kind of RDT we're using. And the one we were using was Paratech, that is detects the antigen for HRP2. And they are quite good, but they remain positive up to a month later after treatment, and they can be positive for at least 2 weeks. That is the median. So having a positive RDT doesn't mean absolutely anything in this lady. And in fact, our protocol said at the time that it shouldn't be even done because it doesn't help us. So what should have been requested that could have been done. Obviously, the lab technician wasn't going to be very happy because it's also time consuming, is to get thick and thin films. Regarding typhoid, well, we know renal test, that is an agglutination test, where you find the antibodies against the Salmonella typhi antigens, has a poor performance. I've put you here a recent article that in fact gives it a relatively good sensitivity, but I've seen as bad as 50% as tossing a coin. And the thing is that this test is widely used in several countries. What problem do we face here is that both treating for malaria and using the test that you have in the cupboard are things that we have learned to do in remote settings. And we've been talking about malaria kills. You have to test for malaria and treat for malaria. And even if the team was aware of the positivity of the test remaining for 2 weeks, they just tend to treat for malaria all the time. This patient deteriorated. She developed abdominal guarding and rebound and was taken to theatre. And we saw that basically her gut was falling apart. It was dissolving in between the surgeon's fingers. I can tell that she didn't have malaria on microscopy. I cannot tell what she had, but typhoid is definitely a possibility with the 3-week complication. So this unfortunate case is just to highlight that is not only about having the availability to have the test on site, but also to be able to indicate them correctly, to know the performance of your test and how they work, and to be able to interpret them, which is more complicated and not always easy. That is a barrier, the interpretation that we are breaching with telemedicine and some help from elsewhere if needed. And to help build up that diagnosis and also to combat antimicrobial resistance, we have in Doctors Without Borders a task force that has 3 pillars: infection control, stewardship, and diagnostic and surveillance. In the interest of time, I'm only going to talk briefly about the 2 at the end. So if we think about the last one, diagnostic, I want to introduce you to Mini Lab. And at the bottom of the slide, you have both the link to the website and also a QR code that will take you to a video that you can watch later on if you can. I think this is absolutely fantastic and revolutionary. So basically, it's a lab that is just dispatched in 6 boxes. You need a space of 15 to 20 square meters to put it in place, and just 2 days to build it up, and also 2 days to repack, which is important if you're just going to an outbreak or something like that. You'll need 2 to 3 laboratory technicians. That can be the technicians already in place. And normally we do 20 days of on-site training, and then during 4 to 6 months, they have online support and regular follow-up visits to know how they're doing and see if it's working. And they can do up to 10 to 20 blood cultures a day, which is absolutely fantastic. If we go closer into it, you'll see the modules. So the first one is a regular reception. So you'll just get the samples, register them as we normally do. Then in module 2, you manipulate the samples. That is whether you have to just prepare them for incubation or anything like that. And then the module 3 is just a simple incubator. On module 4, we have the rhythm bench and interpretation. We also have a module 5 that is very important. That is the water, sanitation, health and safety module that is run not just by the microbiologists, but with the help of the Watson technicians. And then also very important, you have a waste management and autoclave system on the last module. And here is how it looks in reality. And this is one that has been set up 2 months ago in South Sudan. So you can really set it up anywhere as long as you have a bit of space. It can go in a tent, it can go in a container, it can go anywhere. And the second tool I wanted to introduce to you today is Antibiogo. This is MSF trying to bring artificial intelligence to the field, and it's an app that is CE certified that just helps with interpretation of the susceptibility testing. So basically, it will take a picture of the plate. And from the plate, it will say, I have some questions for you. And we'll say, oh, can you see the synergy between the clavulanic and the 3rd generation cephalosporin? This looks like an ESBL. And then we'll help you producing a report that you can still edit and modify as appropriate. But it's something that we really think might help people with less training to do a better reading of the slides. And now what we're going to do is I'm going to hand over to Arjun to present some practical examples. Thank you.
Thanks very much, Marta. And thanks to Melissa for kind of pushing the global health resource limited setting micro agenda, and for Ontario PHO for having us today. So I think Saqib and Marta have talked to you very much about the kind of humanitarian response and emergency response contexts for how micro is kind of badly needed in those scenarios. What we thought might be helpful is for me to give a slightly different perspective about other types of resource limited settings where microbiology can be incredibly useful as well. So I work at a small 100-bedded pediatric non-governmental hospital in the north of Cambodia, in Siem Reap, and microbiology in Cambodia is still kind of a fledgling specialty. There's no kind of formal training program for infectious diseases or microbiology. But the hospital has had a long-term partnership with the University of Oxford, who kind of run in collaboration with the hospital the microbiology lab, which is has a kind of a dual purpose. It's partly there for research into like common infectious diseases for children in Cambodia, but it also runs the diagnostic laboratory service for the hospital, and it's funded by the Wellcome Trust to do that. And so this partnership has been there now for the last 16 years. And so it's kind of a good example of kind of what can be achieved if there's kind of sustained capacity building for microbiology in resource limited settings. So just to kind of illustrate, I thought we'd use a case study. So this is a really typical case that would present to probably the presentation would be typical for anywhere in the world, but it's very common in Siem Reap. So we've got a 19-month-old boy who's presenting with a week's history of fever and cough. He's febrile, tachycardic, and his respiratory rate is at the higher end of normal. He's got bilateral crepitations on lung auscultation, and he's got a leukocytosis with a pretty unexciting CRP. And his urine dipstick didn't reveal any abnormality, and he had a chest X-ray done, which shows, as you can see, a bilateral interstitial shadowing, perhaps more on the right. And the clinical team kind of correctly made a diagnosis of community-acquired pneumonia. He was admitted to the inpatient ward. He was given antipyretics, IV fluids, because everybody is given IV fluids, and started on IV ampicillin. He had a pretty unremarkable clinical course, but by day 5 in the hospital, he was still febrile, and he developed some mild chest indrawing. He still was not hypoxic, and his blood culture, which had been sent on admission, had come back with no growth. So this is a case that we would often be asked about as micro on the ward rounds. What should we do with this kid who's still febrile 5 days into admission? It doesn't seem to be getting better. And that was the critical investigation. So the throat swab was sent, and 24 hours after the throat swab was sent, Burkholderia pseudomallei was isolated, and the patient was switched to ceftazidime, and his fever disappeared within the next 3 days, and he completed a 14-day course of intravenous antibiotics, and then was switched on to cotrimoxazole oral therapy to complete 3 months of the eradication treatment. And at the end of treatment, he was well on follow-up and hadn't had a relapse. So it's great. I think I'm guessing from the response to the poll that many of you were suspecting this, which is great. So for those of you who don't know, so Burkholderia pseudomallei is the causative agent of melioidosis, which is very common in South and Southeast Asia, and also in the northern part of Australia. And as many of you may know, was also recently found to kind of be endemic in parts of the United States last year, and there's an ongoing investigation into that. But it's an incredibly difficult condition to manage for a number of reasons. Firstly, the presentation is pretty kind of nondescript, so the patient can present with pneumonia, they can present with undifferentiated sepsis, and Burkholderia pseudomallei is resistant to most of the first-line antibiotics that are used for the treatment of sepsis. And so the diagnosis really hinges on microbiology. Without good quality microbiology, it's basically impossible to make this diagnosis, and it's extremely difficult for clinicians who are on one hand told to kind of think about antibiotic stewardship and think about not using broad spectrum antibiotics unnecessarily, but on the other hand are also warned about the dangers of untreated sepsis. It's an incredibly difficult position to manage from that perspective. And then you have the other kind of end of the spectrum as well, that once you've stabilized the patient and treated them for 2 weeks with the parenteral treatment, they then have to complete 3 months of eradication treatment with oral drugs, which, as you can imagine, in resource limited settings is extremely difficult, where safety netting and community follow-up is extremely difficult, and attending hospital comes with a massive opportunity cost and out-of-pocket costs for patients. So how did the team know to send those samples? Well, really, it's kind of the consequence of basically a decade of work between the microbiology team and the clinical teams. And for those of you who are interested, this was kind of summarized in the paper that's up here. And it basically is a multitude of clinical and education activities. So you have listed some of the things that the micro team have been doing over the last decade or so to try and kind of establish a culture that microbiology can be useful. So there are kind of daily infection consults for difficult patients. There's weekly rounds specifically geared at teaching the medical students and the interns. There's twice weekly rounds more geared towards kind of clinical management of the sickest patients on the PICU. There's a prescribing app which is freely available called Microguide, which a number of hospitals in the UK use, but is also used by this hospital in Cambodia. And then importantly, the data from the microbiology lab is circulated to all the clinicians and heads of departments very regularly, so they can keep on top of infection control, antibiotic consumption, and also the kind of invasive bacterial infections. And I think it's really important to remember that all of the doctors who are rotating through this hospital, microbiology is a really new concept to them. So when they train at medical school and all the other hospitals they rotate through in Cambodia, they're not used to interpreting blood cultures. They're not used to sending microbiology tests. So actually, when they come, there's a big induction program at the hospital trying to kind of familiarizing them with these different tests and what they're useful for. And I think this is absolutely essential in that, you know, we always talk about antibiotic stewardship in terms of kind of management of infections, but diagnostic stewardship is equally, if not more important. And this was really illustrated to us in a recent project that Saqib and I were working on with MSF in Bangladesh, where we installed a bacterial machine as part of a research study to run blood cultures. And we did a fair amount of training and familiarization at the beginning of the project. But actually, because there was nobody really on the ground to kind of reinforce these messages and work hand in hand with the clinical teams, they really struggled to identify which patients' blood cultures should be sent on and what to do with the results, what the good techniques were for blood culture collection. So we ended up basically with samples being sent inappropriately, so the yield was very low, and those samples that we did get were pretty much all contaminants. And so it was a real lesson in terms of introducing, you know, new technology, how that needs to be supported by long-term capacity building on the ground. And I think the points that Marta and Saqib made in terms of we can't just transplant systems from high income settings to low resource settings. They have to be built from the ground up and built for purpose, because the challenges are very different that we see day to day in these settings. So, for example, we often have drug stockouts or new diagnostic tests, introduced kind of at a whim almost when kind of new donations are made by the Ministry of Health. And this frustrates our local colleagues as much as it does us, and actually working together to try and creatively address this is extremely important. So just as an example of what can be achieved when there is you do have the luxury of kind of sustained presence and capacity building. So this is just a sort of analysis of all the melioid patients that we put together. So this is 355 children with culture confirmed melioidosis over a decade at the hospital. And you can see that actually between over 10 years, there wasn't really much change in kit. There was still manual blood cultures and disc ASTs. The only real difference was that through research funding, identification could move to the MALDI-TOF. But as you can see over the decade, there was a marked improvement in the proportion of patients who were having blood cultures collected who had melioidosis, and also the kind of ancillary specimens, so the throat swab and the urine cultures, which are really important for making a diagnosis of melioidosis, increased. And towards the end of the decade, there were a number of patients who were only diagnosed because they had that throat swab sent. And you can see for a condition like melioidosis, it kind of revolutionizes the management of that patient because the therapy is completely different. And you can see these are kind of soft surrogate outcomes because you can see an improving trend in mortality for the bacteremic patients, but obviously mortality is a very hard thing to budge, but you can see other kind of proxy measures of improvement in quality. So the kind of first line agent for eradication should be cotrimoxazole. You can see a massive uptake in cotrimoxazole versus co-amoxiclav over the decade. And you can also see that the proportion of patients actually managing to complete 12 weeks of eradication therapy really did improve over the decade. So the final thing I'll say just before finishing is that it's really important, as I alluded to kind of provide the local data from surveillance to the local teams on the ground in order to keep them motivated and to show them how microbiology can be useful. And for anyone who's interested, you could just type in this web address, acornamr.net. It's a really nice example of an open source project that's going on using routinely collected clinical data, routinely collected LIMS data, integrating the two and generating kind of locally useful data that hospitals can use to kind of develop treatment guidelines, as well as kind of bringing all that data together from across Asia and Africa to try and look at the global picture. But I think the local use of the data is the important thing here. So I'll finish there. I think we've got 15 minutes for questions, and hand back over to Melissa.
Thank you so much. That was a wonderful presentation. That was done by Dr. Berza, Dr. Gonzalez-San, and Dr. Chandana. So we'll now move to our Q&A pod to address some of your questions. Please continue to enter your questions into the pod if you have not already done so. So I'm going to start off with a couple of questions. So my first question to the team is, how does MSF ensure sustainability of services that are implemented? And I know that you have discussed some of these strategies, but I was hoping you could maybe go into some details and at least tell our group, because in Canada, as you are aware, we have a very large landmass. We have lots of rural and remote areas, and we're wondering how we can kind of build in kind of some of our efforts and lessons learned from the pandemic to improve sustainability of what we have, the technologies we have put in place during the pandemic. So we were hoping we could maybe get some advice from your team.
So I probably can start with that. I think it's a very, very difficult question to answer. MSF has faced the challenge of how to sustainably create projects, and the truth is that all of our projects aren't sustainable. They take a large amount of money, and generally speaking, a good outcome for us as an organization is if we're able to hand it over to another organization to take over, or the government to take over. Increasingly, in my experience, we've started to move away from independent hospitals that MSF have set up to working within government facilities. And this has been a big change for us. With that comes its own challenges, both political and practical. But you know, the old mechanism of MSF kind of rolling in and doing their own thing without asking permission, and just, you know, that's all the years gone by now. Now we don't work without an MOU with the government, and we try and support the systems within the areas that we work. That said, you know, what we try and do is train our staff well, and on the national level staff, so that they are able to continue services once we've gone. But it's very hard for us to guarantee that anything that we do is going to be continued to the quality that we expect in our programs after we've left. So I don't think I have a very good answer for you there. All I can say is that it's a difficult question, and there is no clear or clean answer to it. I don't know if Martha, if you have any thoughts on that as well.
I do agree with you, Saqib. In fact, the example I've given from Central African Republic was already an MOH hospital, and that project started in 2005 and has just very recently closed, and has been handed over to the MOH. When I got there, it was a 100-bed hospital. We were, I think, 150 employees, and we only had the support from 2 employees from the MOH. That, of course, running a 100-bedded hospital with 2 people would have been a big challenge. So I think it's something that we're trying to do better. We're trying to work in partnerships. We're trying to involve the MOH more. We're trying to push for the MOH to take the responsibilities and be part of the projects, but it's still a recipe that hasn't got a solution as yet.
Just to follow up on the response of incorporating kind of the MOH into your responses, do you feel that there becomes challenges? Because as you had mentioned at the start of the presentation, they're all private funders that go to MSF. So when you start partnering with a ministry, do you feel that there is sometimes some changes in kind of outcomes and plans that maybe MSF might find would be in the best interest versus what the ministry finds would be in the best interest? And this might be a little bit of a loaded question.
No, I mean, the answer is of course. I mean, this goes all the way from, for example, a typical hospital that we work in. We don't take the entire hospital over. So we will usually work in a section that could be pediatrics, it could be infectious diseases, it could be a burns unit. But ultimately, the standards that we would work to, ranging from salaries all the way to water sanitation, hygiene, and also making sure the disposal of medical waste is done in an appropriate way, sometimes ends up being isolated to our activities, not the entire hospital, because to take on the responsibility of the entire hospital, it would obviously be a huge task. So they do tend to be these challenges. I mean, even talking about salaries, typically speaking, we don't want to be having salaries that are higher than the government system, because then people will leach people out. But then sometimes it's difficult to get people to come in as well, because there's a lot of other facilities that could be working. They could be working at. So that even that can be a challenge. Yeah, it's all about kind of communication. It's all about working together and building a common objective. Most of the time, I would say that the relationships that we have with the hospitals are very good. With the ministries, they can range from being very good to being, sometimes ministries see us as a challenge. They see us as really being a little bit unwanted, because we tend to speak out a little bit and keep on pushing the buttons to say, well, this is a problem and this is a problem. We have solutions. We always look to be solution orientated, but ultimately we can't fix the system without the support and the collaboration and buy-in of the ministry. And sometimes that's not there. So, and they have their own reasons for that. Some of them political, some of them financial. So we do the best that we can. And yeah.
Thank you for answering my complicated question. But we do have a couple of questions and comments that are in our Q&A pod. The first one I will discuss is, for those who are unable to physically work on site in low resource settings, what are potential ways to contribute remotely to further advance global health microbiology?
I think Marta.
I will take this one. Certainly, I think COVID has shown us that we can do telemedicine, we can collaborate without being in very remote places. When I started in the Central African Republic project that I've shown you, we didn't have internet at all. We communicate ourselves with handsets, and we had a super expensive satellite system to send emails that could only be switched on once a day. That is not the reality anymore. You go to the middle of nowhere, and people are WhatsApping. I think there are many organizations that do telemedicine. I think with the importance of AMR and the WHO view to tackle AMR, there are more and more microbiology labs coming up. And I can think of several smaller and big NGOs that will be delighted to have a microbiologist or ID physician on board. So if you want, I can type on the chat a couple of examples.
I think that would probably be liked by our group very much. Thank you, Marta. There was more so of a comment that was placed into the pod, agreeing with what the group had been saying about the importance of sustainability and integrating the projects that the developed world does within the framework of government systems as well. There's another comment, and it's kind of a question asking about how to strike the balance between global micro priorities and a local micro profile. So kind of asking related to something for Salmonella typhi, which is more global, and looking at efficiencies that can be gained at the global cooperation scale, but those that have local relevance sometimes.
Yeah, so maybe I can take that one. And then maybe it kind of ties into the point the person was making before as well. I mean, I think ultimately the way to deal with this is to invest in people rather than than technology and kit. And if you invest in local people, then you inherently you're gonna build capacity, and it's going to be more sustainable. So to give you the example from Cambodia, so all of the doctors who rotate through the hospital in Cambodia are part of the government training system. The interns part of the national medical system, and so they, the training that they receive at the hospital will then be spread throughout. The idea is that it's spread throughout the country when they move on to the other hospitals. And hospitals also set up the kind of first kind of national training program for microbiology infectious diseases, and they've trained the kind of only 2 microbiologists in the country, who then also will be able to kind of train future generations. So I think by training people and focusing on that, then you can inherently become more sustainable. And that goes to kind of, and to do that, you have to focus on local problems. And I think the project that I mentioned earlier, if people want to check it out, ACON AMR, is all about that. So yes, of course, there is a massive global problem with AMR, which we all need to work together to address. But the way that we do that is by inspiring people to address their local problems in a way that then data can be shared, and then small parts will then kind of deal with the whole problem. But if you ask people in Siem Reap to deal with a problem that's happening in South African Republic, of course they're not going to be interested in that initially. So I think starting local and then trying to join people up to try and address the global problem is the way to deal with that.
I'm going to ask one more very quick question because we're running out of time, but there was a question from our team in Botswana. How do you overcome reagent stockout challenges in government facilities? Do you supply or encourage MOH to take on the responsibility?
Well, Sagib and I have both suffered from this kind of situations together. So what you should aim to do always is to use the system in place. What you can facilitate is sometimes you can help with the orders being done in a timely manner. If you're already doing transport to the field, support the MOH with those transports, so they don't have to book their own ones. And even though if you try very hard, at some point there will be ruptures of stock. It's a bit the nature of the beast. Roads are not accessible all the time. You cannot always get a plane to go to where you have to work, and it's difficult. I think good planning and having a strong supply system is important, and having your own backup just in case the MOH system fails is something to bear in mind.
Thank you so much. So we're at our final minute, so unfortunately I have to wrap everything up. Thank you again so much to Dr. Sakib Birza, Dr. Marta Gonzalez-San, and Dr. Arjun Chanda for presenting. I would also like to thank everyone who joined us for today's session. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you so much and have a wonderful day.